Good evening, everyone, and welcome to Politics and Prose. I'm Brad Graham, the co-owner of the bookstore, along with my wife, Alyssa Muscatine, and we have a great program for you this evening featuring Dr. Deborah Birx, here to talk about her new book, Silent Invasion, The Untold Story of the Trump Administration, COVID-19, and Preventing the Next Pandemic Before It's Too Late. A couple of brief housekeeping notes. First, though, although masks aren't required in the store anymore, we do encourage everyone to wear one during events. And if you'd like a mask, we have them available for you in a holder on the wall there by the front door. When we get to the Q&A portion later, if you have a question, please find your way up to this microphone that's right here in front of the pillar. And at the end, our staff would appreciate it if you would fold up the chairs that you're sitting in and lean them against a bookcase or a pillar. Now, a few words of introduction about Dr. Birx. She served in public health in the U.S. government for more than 40 years, spanning several administrations, starting in the military and then moving into civilian ranks. She spent much of her career researching HIV and working around the globe, combating the pandemics of HIV, TB, and malaria. She's held leadership positions at Walter Reed Medical Center, the CDC, and the State Department, where she served as Ambassador-at-Large and Global AIDS Coordinator. In February 2020, she took up a new position as Coronavirus Response Coordinator within the White House Coronavirus Task Force, and spent a year in that position. When she arrived, the federal response to the burgeoning COVID-19 pandemic was already faltering, and her book is an inside story of what it was like trying to combat the greatest public health crisis of our time while dealing with an ignorant and self-absorbed president, a CDC hampered by institutional malaise and groupthink, and a divided, fearful, and confused public. New York Times review of Dr. Birx's book called it earnest, exhaustive, and excruciating. And indeed, for all the mistakes and misjudgments chronicled by Dr. Birx, she also recounts a number of positive aspects to the response and a number of really heroic actions by individuals, including her own unpublicized efforts to visit a total of 44 states where she met with political figures, university students, public health officials, and local media to stress the need for more testing, more masking, and more social distancing. Such measures, she continues to warn, will remain necessary while the virus persists with its silent invasion. And I think readers will come away with a new appreciation for Dr. Birx, for what she was up against, and for all that she was able to accomplish. In conversation with her this evening will be Sandy Thurman, who also has a distinguished career fighting infectious disease. She worked with Dr. Birx back even in the Clinton administration when Sandy Thurman was the AIDS czar, and as Chief Strategy Officer for the State Department's office coordinating HIV/AIDS activities. She worked with Dr. Birx as well during the Trump years. So, ladies and gentlemen, please join me in welcoming Dr. Deborah Birx and Sandy Thurman.
I see a lot of friends and family. So thank you for coming out tonight. We really want to hear from you and hear your questions, because I'm sure you still have some. And I just really want to thank everyone who's taught me so much about community and community response and how you confront epidemics from the ground level up, and that it's not all at the highest levels of federal government. So Sandy, I think you're supposed to be in charge.
Well, let me just say that for all of you who know Dr. Birx, you know that this is typical. She will always have the first word, and she will always have the last word. So none of us are exactly surprised by this. But I'm really excited to be here with her, of course, and to see so many friends in the audience and talk about this book, which I really think is so important. And I want to just do a little history lesson to frame this, and many of you in this room already know this, but I think for the purposes of our conversation tonight and our conversation about COVID and our conversation about how we prepare ourselves not to get in this ditch in the future and how we get out of it now, it helps to just do a little look back and reflection on what we experienced in the AIDS epidemic. And I keep sort of laughing at the news and folks who keep saying or acting like this is the first time that we've had an epidemic where people were crazy and where there was misinformation and that we were, marred in politics and that there was fear and discrimination and all that sort of thing. This is certainly not the first time we've experienced this. It hasn't been but 40 years ago, and many of us remember this vividly, that we had the exact same thing in the beginning of the AIDS epidemic. We had an American president, President Reagan, who didn't even mention the word AIDS 4 years or 5 years, actually, until the epidemic, before he uttered the word in public. We had really awful people in the White House. Gary Bauer, of course, I think was probably the worst of the lot, who was the senior advisor at the Domestic Policy Council, who had information that was life-saving for folks, given to him by a hero of the epidemic, Everett Koop, C. Everett Koop, but he refused to send it because he thought it would be offensive to talk with the American people about homosexuality or sex of any kind, and so he just sat on the information while hundreds of thousands of people got infected with HIV. So we've had epidemics before that had, great heroes like C. Everett Koop and others, a few villains, and we've seen a few in this epidemic as well, but this is not new to us. And so I think the question for us at this point in time is, how in the world do we forget so quickly, and how in the world do we learn our lessons and embed them in the work that we do going forward? I think about CDC in the old days of HIV, the really early days when they got their budget cut, they were muzzled, they were told they couldn't talk about AIDS in public. They were censored in the words that they could use. They couldn't talk about homosexuality. No one would let them use the word gay. Oh, we're back there again. Welcome to Florida. And so, in all these epidemics, we have lots of villains and lots of heroes. But I think the question is for us, did we learn anything then, and how did we apply what we learned in the AIDS epidemic to our response to COVID? And then what do we learn from our response to COVID as we go forward? And I think that's what we want to talk about tonight, and it's much of what Debbie's book talks about. So I want to start there, madam, and ask you right off the bat, because I know writing a book is a difficult thing, and you're a private person.
If it had been science with data and graphs, I would have been great.
Well, I know, but the rest of us can't read that. So I realized you had to use some adjectives and adverbs, which I know pains you. So I want you to tell us why you decided to write the book. And so talk a little bit about that, because I know it was not an easy decision.
Well, you should have been on the phone calls with HarperCollins on a daily basis, where I would say to them, I'm sending you new graphs, can't I include them? And the editor would say to me, you have to paint that picture in words. And I was like, a simple graph would save 1,000 words, but that's what I tried to do. Hopefully it resonates with people. If I had my way, it would have been 2,000 pages, which I said was a no-go. And then I had to figure out what stories to put in and what stories to take out, which were really difficult for me, because what I wanted to convey, because you all experienced and saw through the media what went wrong, but what no one wanted to talk about, even today, is what was going right. And the leadership that was out there on college campuses by the students and by tribal chairmen, who canceled all their gatherings long before the United States responded. The tribal nations responded because they knew what was at stake. And so there are a lot of heroes at the community level, just like there was in HIV. So I knew that we had to get on the ground. I came back by myself originally. And then Iram, stand up so they can see you. And Amy, both of you stand up. No, really. And Daniel's here too, right? So, okay, so these three people called me up. So I had already gone into the White House. They were still in South Africa working with our PEPFAR program. They came back and said, you can't do this alone. And I think, to me, that's the biggest thing that you can really want to convey, that no matter where you are, there are people that see you, understand what you're going through, and want to help. My first inclination was to say, we don't need any more casualties in this White House, don't come. But I knew that I wouldn't be able to function without the support of this team. And what this team did, and I'm going to get to what your question was. What this team did is we understood from our work in combating HIV in Africa that you need to have data, and you need to have data in real time. And we had created that in sub-Saharan Africa. We could see all 50,000 plus clinics where we were serving individuals. We could see every individual and what their outcome and impact was. We could see year after year if we were making progress. We considered any new HIV infection a failure of our program. That's how seriously we were taking the data. So when I came back, I thought United States of America, iPhones, Amazon, that we would have data. And in my first task force meeting, they handed me a little sheet of paper. It looked like that, with a few numbers on it, and I was like, there has to be secret data. Where's the real data? Where we're looking where the virus is. There was no data. And not only was there no data, there was no systematic way to get the data. And it was like when I was in sub-Saharan Africa in 1998, when I went there and everything was being diagnosed by symptoms. So if you came into a clinic and you didn't look well and you had a fever, they decided you had malaria. And they treated you for malaria. If you didn't get better, then they treated you for bacterial pneumonia. If you didn't get better, they would say, oh my gosh, you might have that virus that's going to kill you, the AIDS virus. And we set about ensuring that every single person, no matter where they lived in Africa, if they had a fever, they had a definitive diagnosis. The companies worked with us to create finger sticks, and we could tell immediately if people had HIV, TB, or malaria. And I come back here and find a country that's diagnosing flu by symptoms. I don't know if you ever had the flu. Really? You called up your doctor, you described the symptoms, they said, I think you have the flu, it's flu season. They gave you treatment for the flu, but they never tested you for flu. So if you go on the CDC website and you look at flu cases, if you look at flu deaths, it's a range. And why is it a range? Because it's all modeled. So here we are, one of the most technology advanced countries on the planet, and I have better data, better laboratories, better definitive diagnosis than I do in the United States of America. And it was an unbelievable crisis, but fortunately, there were people like Daniel and Amy and Iram who understood that we could make this virus visible if we got data. And within days, we had created data streams, and within weeks, we had real tests available because the private sector helped us. But I think it was that fundamental understanding that you have to make things that are invisible visible in order to combat them. People have to know what they have so that they don't give it to others. And people have to be able to utilize data in real time to make a difference. But the flip side of that is data means nothing if the American people can't understand it. So with the data, we worked with presidents and prime ministers and ministers of health and local officials and all the way to the community to make sure everybody understood what that data meant. And that data is available still today at PEPFAR.gov. So if you go there, You can find out what's happening in sub-Saharan Africa. You might not be able to find out what's happening in COVID in the United States, but you can find out what's happening with your taxpayer dollars in sub-Saharan Africa, because you cannot combat infectious diseases without real-time information. And as a country,
Let me interrupt you for
suffer
just a
that.
second, though, because I think this is a really important point. And I think that the people don't understand, or the assumption is that CDC is gathering data and disseminating data. So I think it would be helpful if you explained why that is not the case. And so when people at CDC are talking to us about data, what we think they're telling us and what they can in fact tell us with some certainty is not the same thing. So I think that's helpful
Yes.
if you clarify that.
So right now, if you look at the rates of diabetes in the United States, it's a tiny sampling frame. It's done every 4 or 5 years. There was no impotence to actually do things in real time because there was no program that they were responsible for to change outcomes. So data was historic. Data was something you wrote in the MMWR, which is their report that they put out weekly, or data is something you use in a scientific publication, but it's not something you use to make people's lives better. And I think everybody in the United States knows how to use data to make their lives better. They do it every day. That's why I really wanted to always talk to the millennials, because they understood how to utilize data in great detail. And I think what happened in teaching us about HIV, TB, and malaria on the continent of Africa and throughout sub-Saharan, throughout Asia, is communities are critical for the response. And when you take the public out of public health, you fail. And so what public health people will often do, and you see this sometimes on TV, they say the same thing in the same way, just a little louder each time, or with some adjectival modification. So this is a really bad surge. This is not as bad surge. Remember all the Delta stuff? It's not as bad. The Omicron stuff, it's not as bad. I can tell you, I was writing them saying, it's going to be worse. You're just not looking at the data correctly. And it was worse. We lost 250,000 people with the Omicron surge and 135,000 with the Delta surge, the milder ones. So we're not a super healthy team here in America. We have a lot of comorbidities. We are number 3 in obesity in the world. And we're not doing anything about it. We measure that, we report it, we say it, we do nothing about it. And I think we forget that CDC's name has prevention in it. Control and prevention. And they're not doing anything to prevent the rates of diabetes, hypertension, and obesity that got us in this place to begin with. And so the book is really about that, plus solutions, because we were able to today, in about 75 to 80% of the countries where we've been privileged to work on HIV, have lower rates of new infection of HIV than they did in 1990. We didn't have a vaccine. We had a treatment. And we made sure that every single person that needed that treatment got that treatment, no matter where they lived. So I call your attention today to go to the ASPR website, put in Paxlovid, put in ASPR, and look where Paxlovid is available. If you live in Washington, you'll be able to get it. If you live in Oklahoma, you won't. If you live in a parish of Louisiana, you won't.
Explain what ASPR is.
So that's, not good with all these acronyms.
She worked in
It's the-
government way too long,
It's
and
the
the rest of us
Assistant
can't
Secretary
understand.
for Pandemic Response and Preparedness. So that was another problem that we had. It's in the book about, we didn't ever have this group before, and now we had it, and no one knew who was in charge. Was ASPR in charge or was CDC in charge? And they argued back and forth for the whole time I was in the White House. Anything that went wrong, it was ASPR's fault, and then CDC would tell me it was ASPR's fault, and ASPR would say it was CDC's fault. Witness the testing debacle. When I came back and said, okay, so in the United States, we have the capacity to do millions of RNA tests. Why do we have that capacity? because we had an HIV AIDS pandemic. Because if we hadn't had HIV, we'd have no capacity. So those machines that your PCRs are run on are the machines that we had been using for the last 20 or 30 years to do viral loads for HIV positive individuals. And because of that pandemic, that we believed testing and monitoring was important, we had that equipment not only here, but we had it all over sub-Saharan Africa, and we had it all over Asia. So I come back and say, where is our testing? And I find out that the CDC had created tests only for the public health laboratories. Now, do you know where the public health laboratory in Maryland is? Of course you don't. Because they don't do clinical care. You would never go to a public health laboratory to get your labs run. Oh, someone back there knows. You go, girl. Our public health laboratories are critical, but they were confirmational laboratories. They're the ones that are critical when you have an outbreak, when you have a foodborne illness, when they say, I think there's E. coli in the lettuce. But their equipment may not be the most up-to-date, and it's not high throughput. So when CDC made these tests, they made these tests for a platform that could only run 20 or 30 tests every 4 hours. There were machines sitting in every hospital that could run 1,000 tests every 4 hours. But we never asked anyone to make those tests. We didn't ask them in January, we didn't ask them in February, and we didn't ask them till the 4th of March.
And how far did that set us back? I remember that debacle. So our CDC that we trust to, protect our health, creates these tests or makes these tests that can only be used in a public health laboratory. So once we figured that out, then how long from then was it till we were able to develop tests that we could actually, run in large numbers?
So I came to the White House with a list. So I didn't know anybody in the White House. I only knew Matt Pottinger, and he's responsible for the book, for what happened to me for 11 months, because he was driving me crazy, calling me and writing me continuously in January and February, saying you had to come to the White House. And I kept saying, for those of you who have seen on the media what was happening in the White House, I kept saying no. That seemed like a reasonable response to me at the time. But then I saw the tsunami wave coming and felt like I had to go. But when I came to the White House, there was no plans to develop any tests. So I gave Vice President Pence, and I have to say, in my mind, he's a hero because he didn't know me from Adam. He didn't know me at all. I was never on a campaign. I never worked in the Republican Party. I was a complete outsider to this White House. And I came in with a list of 5 things we had to do that week, and he made all 5 of them happen. And the critical one about testing, this is when I knew, well, Sandy had been in the White House and she had always told me it was different. And I never realized how different it was because I gave the vice president a list and I said, here are the people to invite to the White House by names of companies. I said, invite Abbott, invite Roche, because these are the companies I knew that had made the RNA tests that we utilized in HIV. Well, when I walked into the room that Wednesday, just 48 hours later, every CEO of the company was there. Now, I'm used to the lab technicians coming and that are making the assays. I'm used to having that discussion. I'm not used to CEOs, but every CEO came. And within literally 2 weeks, we had tests. And so that tells me that if that had happened in January, this wouldn't have been invisible to you all. And it wouldn't have hit the East Coast in the way it did, because we would have known the virus was here. So by the time we found the virus, it was already so widespread. So this is my public health message. Do not be tracking hospitalization as your indicator for whether there's a problem of viral spread in your community, because that's 3 to 4 weeks into viral spread and too late to do anything. Grandma and your aunts and your immunosuppressed individuals are already getting infected. So you have to have data that shows you where the virus is when it first starts to move into your community. It's easy to find. It always starts in the younger kids. They're usually asymptomatic or a little bit runny nose. They infect their parents. Their parents infect their coworkers. The coworkers infect their grandparents and their aunts and uncles. And that cycle takes about 4 weeks before the sick aunt with breast cancer gets admitted to the hospital and is dying. It's too late. So when we say that we're just going to ensure that our hospitals aren't overrun, that's going to do nothing to stop the viral spread in the communities. When we all know what to do to stop it in that moment, and you don't have to do it all the time. There's times when there's virus there, and there's times when there isn't virus. There's natural laws between the spikes, and we can see them. We know how to predict them. We know that this virus, when it's coming, where it's going, what populations it's going to impact, what the months are that it's going to do that, in what areas, and we know what variants are predictable. We know all these things now. Yet we still are doing this magical thinking. Do you remember when they were all in the media were saying this was going to be our last spike 3 spikes ago? I mean, that just makes us depressed. Let's just go with the data, know that the virus is going to do these things, and we are smarter. I can promise you we're much smarter than a single-strand RNA virus. And if we use our intelligence and the data, we can prevent people dying. But right now, our job should be that any hospitalization and any deaths is a failure of our programming. Full stop. That's how we stopped HIV. We said any new infection, any HIV death is a failure.
Okay, let me stop you there because
Yes.
you still haven't answered my question.
Yeah, which
All right.
one was that?
So, you see, it's hard to stop her. It's like a train. So,
Imagine being the person editing the book.
I know, I feel really badly for them. But that's, let me ask you something. So let's go back to the book. But a lot of people have
And we
written.
want to get to their questions.
Okay,
So
well,
this
what-
might be your last
It
one.
is. No, well, I'll tell you when it's my last one. So, so let's go back to why you wrote the book. A lot of people have written books about COVID and their experience during this period of time. But so what made you want to write this book? Because it was difficult to do. And then what do you hope we all get out of reading your book? So tell us that.
So when I left, it was clear to me that we were going to make the same mistakes all over again through 2021. And that was very upsetting to me because we'd already made those mistakes in 2020. We didn't need to make them in 2021, and we didn't certainly need to make them in 2022. And I just really wanted to write both what went terribly wrong, what went right, and what I saw out in the country, which was amazing work at universities by the students. It just amazing work. So I wanted people to know that they weren't really seeing everything that was going on in the ground, and a lot of good work was happening. But I also wanted to write that we're not using data to really change the course of this pandemic. And that's very upsetting to me still. So the whole last chapter is on what we continue to do wrong. And then there's an appendix of 9 pages telling people exactly what Congress needs to do, what kind of legal framework, what kind of appropriations they need to make to change the future of our pandemics. Because stop working on pandemic preparedness for the next pandemic. Stop it. Just stop it. Stop wasting money on that. Start right now making your goal no one dies and no one gets hospitalized from COVID. And I can promise you, if you put those programs in place, you will address the inequities that exist in our rural healthcare system, because there is not one. The reason people are dying in red counties is because they have no access to healthcare. They get their healthcare from an emergency room that's 3.5 hours away. The majority, 2/3 of this country, lives in areas without any referral hospital within 60 minutes. Do you know how many level 1? Now, level 1 trauma is just an illustration for advanced medical care. It's the top level of trauma. It means that you have ICUs and surgeons and high level of capability. Do you know how many level 1 trauma centers there are in the New York metro area, New York City metro area? 22. How many are there in Mississippi? 1. Very good.
Thank you, Professor.
That was excellent. 2 in Louisiana. So when you wonder why people are dying in rural America, they're dying in rural America because they have no access to health care. They have no one to go to talk about vaccines. They'll say, oh, well, there's vaccines in that pharmacy, but who are they going to ask their questions to? Who's going to answer their questions about what those vaccines do? Who's going to ask their questions about where they're going to find Paxlovid? So if we take the position that no one should die from COVID-19 because we have the tools, then we have to fix all those access issues. And those were the access issues that we fixed in sub-Saharan Africa. So if I can fix them in rural Uganda, if I can say to the president of Kenya, you are underserving the Lua tribe because they didn't vote for you, and move money to serve them and change the entire pandemic in the Lua tribal area. If we can do that with data, independent of who's president or who's governor or who's mayor, you do that on the ground level by investing in the things that make a difference. So putting more money in our institutions that have failed us and continue to fail us is not going to result in something different. And so that's why I wrote the book. It has a really, I hope, very clear way forward. And it's a way forward that I personally have lived. I see many of my colleagues here from HIV who have lived it and have taken the time to teach me so that I understand it and I can do better. And that's what we need to bring back to the United States. We have to stop our arrogance, our finger pointing, our disregard for each other, our inability to listen. I listen to every governor. I don't care if they were a red state or a blue state. I learned from both of them. Both of them taught me how to do this better. And then we came back and we told other governors, this is what they're doing. And Governor Tate Reeves had the best example of what you do during a surge. You turn the dimmer down. And when you get through it, you turn the dimmer back up. And that's how you mitigate. Governor Ivey in Alabama said, mitigation, it's just like Swiss cheese. Vaccines, layer 1, still has a lot of holes. Let me make it clear to all of you in this room, vaccines are not going to keep you from getting infected. They're not going to keep you from passing it on to your grandmother. Vaccines may not even be protecting your grandmother because she didn't develop an immune response. I won't go into the details, but we have these things called telomeres. It's what makes us old. It's why we droop. You know, our collagen, everything's going, our joints, our skin. Our telomeres, they're getting shorter and shorter. Happens in the immune system. So when you're 80 and 90, I don't know if you have an immune response that's effective. So just because you got a vaccine does not make you Superman. Does not make your grandmother Superman. And that's what Kate Ivey was trying to say to us. Swiss cheese, layer 1 vaccine, layer 2, if virus is spreading in your community, you mask if you don't want to get infected. Now, some of you may not care if you get infected, but let me tell you, I don't know how well the vaccine protects against long COVID. I think it does. The data, still not available. It should be. I don't know how well it protects against the late-stage cardiovascular findings, and I don't know how well it protects against the brain findings. So I'm not cavalier about it. And my family members who I see here, who are masked, thank you. There's 13 of us. None of us have gotten COVID. We are very strict. There are things that we don't do. We'd like to do them, we just don't do them. Because I've got a 93-year-old mother, and my daughter, who's amazing, who's here, has 3 children under 5. That's a lot of children under 5. Lots. It's a lot of children, Danielle. Lots. And my other daughter's husband is here, but I don't see my other daughter, but I don't. Is she there? She's so tiny.
There she is.
Hi, Devin. So I have 2 amazing daughters. That's who the book is dedicated to. But we have to be very real with what we know about this virus, and we have to stop pretending that we don't know, because we do know. And so we really need to take this seriously during a surge. When we're not in a surge, when we're in a lull, you can take off a few layers of that Swiss cheese.
Excellent. All right, let's let people ask a question.
Yes.
Okay, how about that? Do we have questions?
I
Yes,
think
sir.
you're supposed to come to this
Yes,
microphone,
come to the microphone.
because they're recording your incredible question.
Okay. First, thank you for going into an unbelievably difficult environment to serve the public after you had already given so much during the AIDS epidemic. I'm grateful as a
Thank
citizen
you.
and person. When I hear your kind of lessons learned and your critiques, kind of piecemeal of lack of access, taking the public out of public health, lack of data, lack of testing, lack of access, what I'm hearing is a critique of the private for-profit healthcare system we've established in our country, which I think is totally fair. The only glimpse that my children have had of socialized medicine or government-provided medicine was during the healthcare. It was during this epidemic, where they had access to healthcare, in ways that they didn't. My question for you is, why not join the discussion at that level? Because it would seem to me that, our country is in the middle of this debate. Bernie Sanders' point is, Medicare for all. And my children have no faith in a privatized for-profit healthcare system. Why not join the debate on that basis?
I think that is a valuable debate, but I want to fix things now, and I think that's a long-term solution to really have that discussion. I do have to disagree with you just a bit on the private sector, because that was one of my surprises. And I think the one thing that the Trump White House understood was business, and so they really drove treatment. They drove testing, believe it or not. While the president was saying testing was not needed, we were spending $3 billion on expanding testing. So, there was this huge dichotomy. But the private sector, when I called up the major suppliers, and there's 6 major suppliers of all medical equipment and treatment, Cardinal, McKesson, Henry Schein, AmerisourceBergen, and a couple that I can't remember. And I said to them, stop sending product based on people who are paying you, because it was all going to California and they didn't need it. And send product to the places where I say they're needed based on data. And they rearranged their entire supply chain, not based on profit, but to get treatment to these community hospitals that were out in rural Oklahoma, and to get PPE to those nurses, based on the data. And they used that data to create equity. And I was surprised by that, because they could have done it differently. But they stopped doing what they were doing and did it in a way to save American lives. And so I think I think things are not as one and two dimensional as we would like them to be, and as simple solutions as we'd like them to be. I found people, and so while the president was not letting me speak nationally, his very own White House communication team was making 20 and 30 media hits for me every day with the local stations, so that people would know that there was virus in their community and what actions to take. So, it wasn't this one-dimensional easy piece. And I think with the solution that you're talking about, I think there's definitely, like the Indian Health Service is as you described. It's socialized type medicine. They failed many.
Well, England too. I wouldn't use India.
So,
as
our
the
medical
benchmark.
is not as perfect as we'd like it to be. So we have work to do. But I think it starts with data, and then you can find all of those issues that you're describing, and you can combat them one by one.
Good. Thank you. Do we have another question?
Here we do.
Right here. Good.
An obvious frustration is that the issues surrounding COVID became so politicized and divisive that for a great many people, the data, to the extent it existed, and the science didn't seem to matter. Indeed, it became a badge of honor to ignore it. So my question is, do you believe that we're at a point where the data and the science still can break through that effectively?
I think it could, but you have to be truthful to the American people. And I don't think we're still being truthful to the American people. I think we weren't truthful on masks. I think it confused them. And I heard that as soon as I got out into the States. People asked me very point blank, you're telling me to make these 2-ply cloth masks as a minimum. Then you're telling me they only work one direction. How is that possible? And you're like, well, it's not possible. But they're like, oh, on the CDC website, it says it doesn't protect you from infection. So why aren't the droplets blocked coming in if they're blocked going out? We lost people. They felt like they were lied to because we weren't using science and data. Instead of doing the experiment to show that the cloth masks work and how they worked and show that on a TV screen with a graph, I could never get them to do the study. Because ASPR pointed to CDC, CDC pointed to ASPR, and then they both would point to DHS. I mean, it was the craziest thing. In the end, Japan did the study and published it in October of 2020. We did the same thing with vaccines. And I want to be very clear about that. These vaccines that were developed, they were only studied for symptomatic disease, hospitalization, and death. We never tested patients for asymptomatic or mild infection. We had no idea if the vaccines protected against infection, and we didn't know how long they protected against anything. These weren't measles, mumps, and rubella. Now, I see some people that are kind of my age, and you probably had measles, mumps, or rubella. And you're protected for life from measles, mumps, and rubella. And the vaccine that's made like natural infection protects children for life against measles, mumps, and rubella. Sometimes if you're pregnant, you need to get a booster dose. But in general, those vaccines are very effective. This vaccine is not that. But when the media and everybody gets out there and says, this is going to create herd immunity is only possible when you have protection against infection. Because vaccinated people now become the spreaders, as well as the unvaccinated. So when I went out then over this last year, because I still go out to states and try to understand what's going on, there's a whole group of people who feel betrayed because you told them the vaccine was going to do this. It didn't. It did a great thing. It protected most people from severe disease and hospitalization. That should be good enough, but we should tell people that's what it does, that it doesn't protect against infection. Because now people believe that the science we're being lied to. And so I think if you're going to go forward and say you're using science and data, you actually have to use the science and data. And when you ask people to do something, you have to show the data and the information behind that. So they know that there's information that actually proves what they're saying. And I think then you'll recapture people back because there are a lot of myths in sub-Saharan Africa about how HIV is spread. And there were a lot of myths about how you could get rid of HIV by taking a shower, sleeping with a virgin. I mean, the list was long. And we had to combat those things point by point. And you can with science and data, but you have to actually use science and data. So that's my other big point. You cannot do pandemics by polling. And you can't do programs by slogans. So if you're going to do test and treat, which I believe in, then you actually have to do test and treat, which means that you have to ensure that everybody can test when they need it and everybody can treat when you need it. And you have to you have to then know whether you're actually able to do that or not. You just can't put out, what if I just had made up stuff like a program, which we did do, that was very good, we never made it up, called DREAMS, Determined, Resilient, Empowered, AIDS-Free, Mentored, and Safe Young Women. I see my DREAMS team here, unbelievable. That's the team. See, these teams are tiny, 4 or 5 women committed to changing the course of HIV infection in young women in Africa. That's what they did. We had a plan, they did it. That's what's possible when you use science and data and you get down to the ground and you talk to the young women. And you listen to the young women ask their questions, and no question is wrong, and no question is stupid, and they answer every single question. Those young women then became the most empowered young women. They were taking on their ministers of health and saying, this is what I need. No, I don't need that. And they would come back to us, and we would have meetings with them, and they would say, this is working in Mozambique, why don't we have it in Uganda? I mean, it was extraordinary. They were communicating with each other and making things better. So when you say you have a program and it's called Test and Treat, where is it? Where's the plan? How are people in Oklahoma going to get the drug? How are people in Louisiana parishes going to get the drug? How is that going to happen? Where is that plan, and where are the details with the plan? Don't tell me you put Paxlovid in a pharmacy and that's your plan, because that's not a program. That's a sentence with nothing behind it. And if we had taken that approach with HIV, there would still be a raging pandemic in sub-Saharan Africa. And we as Americans are letting this happen every day in this country, and we just can't. We have to make it stop. Yes, you have a question.
Yeah, I hope this is not tangential. If it is, let me know. For example, President Biden is often saying, we're going to follow the science. And
Then you have to do the science.
well, for example, one person who I think is very intelligent, Bill Maher, I see him several times talking, and he'll point out some mistakes that were made, and he comes to the conclusion, we don't know shit. So my question is, do people understand what is meant by science and what it means to follow science?
Well, science is nothing more than data. It's experiments. And so you can do experiments at the population level. You can do it in a test tube. You can do it in a plastic dish. Let me give you an illustration. If you tonight go home and look up Our World in Data or on Worldometer and pull up the UK cases and fatalities through each of their surges, and pull up the United States cases and fatalities through all of our surges, and you will see that there's a dramatic difference in fatalities in Delta and Omicron in the UK compared to the US. What did they do differently? They made testing available for free to anyone who wanted it at any time, and they ensured that every person in the UK knew that before they went to see a vulnerable family member, they should test. So there is population-based data now that confirms what I was saying in the book about the role of testing, and that is why I called the book Silent Invasion for two reasons. One, I'm a big sci-fi person, and Dune and I are like, even his son is writing beautiful Dune books. I've read both the dad's and the son's. Dune is lovely. The movie was like all the books in one, but it's okay. It did a pretty good job. I wanted it to appeal to sci-fi people, but I also wanted people to know that this virus can still circulate silently in the community and be invisible, and the only way to make it visible is through testing and data. So part of what Bill Maher is saying and why we're still on this ditch is our data is not available in a public website, continuously updated, so that every American knows what's happening in their zip code and in their county.
Good evening. Thank you for your service. Tremendous. My question is, we do sort of have socialized medicine in the form of DoD and TRICARE.
Yes.
How is that lens of getting data and implementing interventions for COVID, how useful is that compared to the non-DoD world in the United States?
Yeah, so that's a great question. And the other group that also socialized medicine is our VA system. And the VA data was very helpful because it clearly showed months ago that, and that's how I still do data every morning. I still write PowerPoints once a week because I feel morally obligated that we have to make sure that people understand what's going on. And the VA was one of the first groups that were alerting us to the hospitalizations and deaths despite being vaccinated. And so these systems are critically important and remain critically important. For those of you who are in the military skews, of course, very young. And because of their stupid weight requirements, we can't really be that overweight. I was in the military for 29 years, so it was a lot of very strict requirements about obesity. And so it doesn't really mirror a lot of the U.S. population, but as far as infections, very good at understanding. And that's why we knew how severe the asymptomatic spread was, because we could see it in the Diamond Princess, and we could see it, I think, in the Roosevelt very early on. And the military was very helpful in getting us that data.
Thank you.
I
Hi.
think we have two more.
Just
So if you want to ask a question, get to the microphone because it's 5 of 8. Yes.
so really quickly, I feel like I heard you say this earlier. I just want to create some clarity for it with the CDC's use of data and how they were presenting it. And so, you know, I understand that when I'm looking at Google Maps on how to get to Chevy Chase, Maryland from downtown DC, that the fact that there is some congestion in downtown Topeka will likely not help me get here. So my question to you really is that with the work that the CDC was doing on data and sort of not really being there ever, and what you discovered when you got here, would you say the CDC might be responsible for a lot more of our fatalities and mortality in this country because of the fact that they did not care to actually know where COVID was in this country at the time that when you started working all the way through to when you stopped working on the project?
Yeah, so, you know, there are good people at the CDC, and I just want to acknowledge that. But I was sent to the CDC in 2005 because they were failing on PEPFAR. And they were failing in ability to implement a program, use data in that implementation to constantly do program improvement, because they had to become a institution of historic data analysis where there's no real urgency to the analysis and therefore no urgency to have it displayed. And so if CDC is going to be our one and only public health institution that is going to continue to have the role on protecting us as a country, they have to have substantial reforms, and there has to be real-time data available to every American. In the same way, remember, I hate to say this, but you know, everybody knows what's wrong with every one of you. It's in electronic medical records. Now, I don't have access to it, but I mean, it's all electronic, okay? It is all electronic. So the fact that you can't pull that data in an anonymized way, which you can, because you don't know what cars are in that pile up that are in that congested area, but their phones are telling everybody that they're stuck there. So, I mean, we use people's data all the time, so that data could be pulled from electronic medical records, and then we would know every failure that we were having in the program in real time. The fact that CDC chose to publish the end of April, that half the people admitted to the hospital in January were vaccinated, that would have changed our behaviors. I think it was important. They published it the end of April for something that happened in January. We were past the surge in April. So this is what I'm talking about. They've got to step up their game. It's great that they brought in forecasters, but you can only forecast what's going to happen in the pandemic if you collect data in real time. And it shouldn't ever belong to an institution. It should belong to the American people. And that's how we changed the course of the pandemic in Africa. We made data available to everybody, independent of what your job was or where you lived. You could see what was going on. And then you could ask your government, why is this clinic over here doing better than this clinic over there? And you know what? The clinic that isn't doing as well gets better. Okay, we're going to do the 2 questions. Yep. You're doing such a good job moderating.
Like herding cats.
Hello everyone, thank you so much. I'm from Ukraine. My name is Yana. I was born with HIV. So first of all, I want to say thank you for all of us, like the whole community from Ukraine, because now we have a war, and our like HIV very brave activists to fighting for Russian militaries, and we just saved a lot of people with living with HIV. So so that's why I'm just saying like thank you, because you were in PEPFAR, and PEPFAR is very helpful for all process were made by all the Ukrainians. So my question, like, it's much more international. Like, which country? What do you think? Which country they have made the best practice with COVID?
Yeah, so I think I talked about the UK because they make data available. They were sequencing at extraordinarily high rates, and they were making testing available. Now they're dismantling testing, so I'm a little bit worried about that. And they did that without restricting people's movements. And I think that's really critically important, is how you get there. I want to just mention what the Ukraine did for HIV, because I think it's really phenomenal. They realized that many of their marginalized individuals who were most at risk for getting infected with HIV were people who injected drugs that really didn't want to be visible to the federal government, the national government. And so the national government worked with AIDS Alliance, an NGO, to provide services directly to the people most in need. So sometimes you have to step back and say, I'm not going to be successful. This group can be more successful. They're of the community. They know how to do outreach. They know how to talk to people and invested in them. So not all programs have to be government programs to be successful. So thank you.
Hi, Dr. Birx. So I can ask this for you now because we're out of the West Wing, but every morning you would take a sigh coming into the West Wing and we would see each other. What did you find to be the most challenging about the political environment there, and what did you find to be the most surprising in a positive way about the political environment?
You came so dressed down today.
I'm not doing the bow tie today, no.
So every morning, he would be there. As I would come crawling in with no sleep, having done data. Beautifully dressed, meticulously dressed, and he had to do the security briefing. And was having as much success as I was on conveying what was going on. He was conveying what was going on security-wise, and I was trying to convey what was going on in the pandemic. And just your presence, your smile with your eyes, because we were masking. We were the only people masking in the West Wing, got me through the day, because I knew you were going through what I was going through. And we would joke about when COVID was really bad and countries would lock down, his world got a lot better. Because the terrorists couldn't move as easily between countries. So my work got worse, his work got better, and you were such a colleague. And I just really want to thank you, because there were a lot of people who were really doing everything they could every day in their sphere of influence to make a difference. And I know there's some federal workers here. I just want to thank you, because federal workers get, when administrations think we're trying to make their lives hard. Sometimes we are. But federal workers are the backbone of when we talk about the Trump administration. It's really, a million federal workers that every day are coming to work to try to do what's best for the American people. And I know you did that every day. And thank you for encouraging me, because knowing you would be there and your job was hard and my job was hard made my life so much better. So thank you. Why don't you come over here? She probably doesn't want to be on camera.
That's okay.
Oh, you don't at all? Okay. Well, he was with the secret people.
You've just been outed. No.
There's part of that secret group. But, after 9/11, we fixed our national intelligence a lot. We did. And those groups worked together. I think we need to take this same serious approach to how we deal with pandemics and infectious diseases in this country. And we have to fix this. We fixed things before. We can again. I really want to thank you for coming out tonight. I want to thank the Dreams team from PEPFAR and all the work that you do. You really are remarkable how groups of 4 and 5 people can change the world. They really can. When they're united in a mission, they can do amazing things. To the data team, Daniel, Iram. Iram led the data team. She had to set up this data independent of our agencies because they wouldn't. And I think what people don't realize is the CDC told me no. That's why we set up the hospital database. Do you think I wanted to set up a hospital database separate from the CDC? Of course I didn't. I asked them for 3 months. If you know me, that's a long period of time. Every day, 3 months. Set up the data, set up the data. Sent Amy down to the CDC in Atlanta. Set up the data, set up the data. No, no, no. And we finally just said, we need to have the data. We need to know who is in that bed and if they need medication. And we're going to make that happen. So, thank you. Yes.
Great. Well,
Excellent.
thank you, Debbie, and thank you, Sandy. So copies of Dr. Birx's book are available at the checkout desk. She'll be up here signing. Please form a line.